So I think we are good to start, or should we wait for more 5 minutes for others to join?
So we can wait for just a few more minutes and then we can start.
Fine, will do. So we can wait for more 3 minutes and then we'll start for 3 minutes. No worries.
Sure, sir. Good afternoon, sir. Good afternoon, everyone. We can start the session now, sir.
Perfect. So, good afternoon, everyone. And thanks a lot for joining this session. So, thank you first of all, thank you to Eco Platform for this platform so that, there's a very good sharing of knowledge over here everywhere. And this is the best way to actually disseminate this knowledge till the field. So this is my first slide, which I always present in all my presentation. The reason is only one. It is not an obsession, but as we all know, fighting TB alone with public sector is not possible. Only along with private sector is not possible all alone. So until and unless each organize together, it is next to impossible. So if we need to definitely think of elimination of tuberculosis, each and every sector organization working in field of TB should join hands together to fight against this TB. Let it be central government, let it be the state government, let it be the corporation, let it be the private NGOs or the private organizations in that matter. As we all know, the treatment of DRTB with good at least 16 to 18 pills per day is what we used to offer. 18 minimum long months and even 24 months along with injectables. But now, luckily, there are regimens which are without injectable. And more than that, it is not only without injectable, but now the regimen has come with minimal drugs and minimal side effects. But each and every drugs which a patient takes have their own side effect. Let it be any single small drug. Each and every drug have their own side effect, and that's what we are going to touch upon in this today's presentation. We're just going to tackle. We're just going to see what respective side effects are of each and every respective pills and how to tackle them timely. Because the clinician who is able to tackle these ADR timely, the clinician who is able to manage ADR timely is definitely going to do justice to the patient to reach to the outcome at least till treatment completion, right? So this presentation is solely for educational purpose. I do not intend to promote or endorse any specific drug or brand mentioned in this presentation. Let me be very clear, right? So as we all know, first line drugs, second line drugs. In field of tuberculosis, we have first line drugs, that is isoniazid, rifampicin, pyrazinamide, ethambutol. Streptomycin injectable was there, but it is no more a first line drug now. It has been absolute from the entire drug list, right? So just because we are moving towards the injectable free regimen. And second line drug, as we all know, includes of bedaquiline, delaminate, pritomanide, ichoramide, cycloserine, paramedic salicylic acid, rifabutin, fluoroquinolone, all group of quinolone drugs, and all injectables. So these are all second line injectable. So we'll just touch upon the ADR of each and every drug and how to tackle each and everything, right? So starting with the first thing, like orange discoloration of body fluid, or most commonly orange discoloration of urine in that matter. Yes, we all know when we see orange fluid, one thing which comes and should come in mind, which is also a culprit drug, a most common drug for hepatitis, right? Where the liver enzymes get deranged. And yes, if this drug has come in your mind, you're absolutely right. It is none other than rifampicin. We all know rifampicin turns our urine, not only urine, even sweat in that matter, in orange color. And that is just a color. It is nothing to do with hematuria. This is not hematuria. It is only coloration of the capsule or the rifampicin drug which is there, right? Well, other ADR for rifampicin are cutaneous syndromes, abdominal type syndromes, flu-like syndrome, a respiratory syndrome, like when the patient start taking rifampicin drug, he must have come to you in an OPD within the next 7 days, and you would have been heard this complaint that दवा लेने के बाद छींके चालू हो रही है, नाक से पानी आ रहा है, right? या कभी कभी even खुजलाहट हो रही है. So these are nothing but all flu-like syndrome, which is because of drug rifampicin. The most common side effect. Now, let us start going one by one. Hematological toxicity. Now, can you see this red hemorrhagic petechiae over here on the skin? Yeah, this is what we see when the patient is on anticoagulant therapy, and when sometimes the PTNR is deranged and patient starts having, or patient has thrombocytopenia due to some reasons. So yes, you can see this red petechial hemorrhages, which is present everywhere throughout the body, ready with the neck, the trunk, even the tongue. These are the small red petechial hemorrhages which we can see, right? Even on the back region, the suprascapular, the infrascapular region. So all these on the limbs, the extremities, the lower limbs. These are also the lower limbs petechial hemorrhages. So this is nothing but, yes, you are right. It is because of the thrombocytopenia, which is caused because of two drugs. The most common drug over here is rifampicin. Rifampicin induced thrombocytopenia. That is a very common side effect, which we failed to pick it up at the earlier phases many times, right? Rifampicin, along with flu-like syndrome, along with rashes, itching, we also see a platelet drop in the CBC of the patient. That is because of rifampicin. The second important drug causing this hematological problem is linezolid, where we all know linezolid. When linezolid drug comes in our mind, what comes immediately is peripheral neuropathy. Yes, that's very right. But along with peripheral neuropathy, it also causes myelosuppression. That is, myelosuppression is nothing but pancytopenia, decrease in the hemoglobin levels, the platelet counts, the WBC also many times all goes down. That is also because of the linezolid. So these are the two drugs causing hematological problem, rifampicin and linezolid. First is thrombocytopenia, right? Note, linezolid containing regimen must not be offered to the patient if the hemoglobin is lesser than 8 grams per deciliter. You think of some steps taking care of the hemoglobin, build up the hemoglobin, and then you can include this drug in the regimen, right? And second is the rifampicin causing induced thrombocytopenia, right? So this is one case where HB falling, we have seen cases from HB falling right from 11 gram per deciliter to directly 3.7 gram per because of the linezolid. Patient was on linezolid and patient developed a 0.7 gram per deciliter. So this was a patient on rifampicin, similar to linezolid. This is what the patient turned to us within 5 days of starting first line drugs, that is FDCs. Within 70, just 2 days of period, if you can see the interval period over here, the lesions has increased over here. The CBC, when we got a CBC done, CBC, there was a fall in the parameters over here. The baseline, if you can see over here on day one, was 5.5 per deciliter, 5,000 per deciliter, platelet was 2.20 per deciliter, and within just 5 days, platelet count also went down just to 30,000. So 30,000 is something which is not normal. We all know if it goes below 20,000, he may also need a transfusion. So yes, this was because of the linezolid. So these are the patients, which if you can see these lesions on the tongue, classical active hemorrhages on the tongue. We can see petechial hemorrhages over here on the extremities. So yes, this is nothing but thrombocytopenia because of maybe either rifampicin or linezolid. So this was the case because of the rifampicin. So yes, what we did, we had to stop rifampicin immediately. We shifted the drug, replaced it with levofloxacin, and then the patient was being continued with the levoflox-based regimen, right? So sometimes what we do is we do a rechallenging, the dechallenging and rechallenging of the drug. So, but for cases like these, where the anemia, whether there is severe drop in hemoglobin or whether severe drop in platelet count, do not even dare to re-challenge such drugs. It is best way is to replace the drug with some other active ingredient. Coming to a second case over here, if you can see, if you can appreciate, this is the normal skin over here on the extremities, and these are hyperpigmented, dry, scaly keratotic lesions, right? So when you see, there's a clear-cut demarcating line, if you see, between the normal skin and the affected skin. Now, yes, this happens with just within the 3 weeks of starting some first-line drugs. Now, which is the first-line drugs? So we'll see that. Can you see this? So this was the normal skin over here, and this was the classical line, a demarcating line between the two, the affected area and the normal area. So yes, this is the patient on isoniazid, nothing but palagroid dermatitis. So isoniazid and isoniazid, both these drugs causes this particular side effect, that is palagroid reactions, right? Pellagra, what it is? It's nothing but a niacin deficiency disorder characterized by diarrhea, dermatitis, and dementia. We all know 3 Ds of this particular problem, that is pellagra. So this is nothing but INH and iconiamide. These are the two drugs which causes the same problem, palagroid dermatitis. Do not stop isoniazid. Do not stop etonomide. If it is going on in your second line drugs. What you need to do is just add nicotinamide 100 milligram 3 times in a day for 1 month period, and you will see magic. Yes, if you see this particular case, you can see a clear-cut demarcating line between the normal and the affected part over here. This is what is palagroid dermatitis. What do we do? Do not the drug. These are all different cases. Next case, a classical normal skin over here and hyperpigmented dry keratotic lesion over here. Yes, these are palagroid dermatitis. Because of isoniazid, even etonomide leads to the same problem. This happens in both extremities, upper limb as well as lower limb. If you see lower limb, what do we do to stop the drug? No, do not stop the drug. Nicotinamide 100 milligram, just orally divided dose three times in a day for a period of 1 month. And this is the magic what you see. Without stopping the drug, just give nicotinamide, you will see absolutely normal skin within a period of just 1 month. That's it. This is what the lower extremities are now. No stopping of the drugs. Just nicotinamide was been given to this patient. See the difference, the previous and the later one, right? All clear, absolutely normal skin. This is because of nicotinamide 100 milligrams. So how do you get nicotinamide? So this was another case. A Cobadex C as nicotinamide. It is nothing but the multivitamin. B6 is the multivitamin which we give for our patient. And this is what patient show the improvement. So this was the affected area, the normal area. And this is what you see after giving nicotinamide. That is Cobadex CSZ, 100 milligram, 3 times in a day for just 30 days. And this is the magic you see. So there is no need to stop the drug always unless and until there is die-hard emergency, right? Coming to the next problem. So yes, as we all know, a male coming with such presentation, the left side swelling on both sides of the chest. Yes, you are right. This is nothing but gynecomastia. The gynecomastia can happen, that is a male breast, which you can see in the males normally. You see this? Not normally, but the patient who are on, again, the same two drugs which causes palagroid dermatitis or palagroid reaction also causes the same problem, that is the gynecomastia, right? So it's nothing but isoniazid and etonomide. These are the two drugs which causes gynecomastia. No need to stop drugs. Just counsel, reassure your patient. Do not worry. Once the drug has been stopped, all this will be taken care of. There is no need to go with surgeries also in that matter, right? Coming to a next side effect again. When this comes in front of you, where you are unable to read, impaired vision, yes, suddenly patient complains within 3 weeks of starting AKT, I am unable to see clearly. There is a blurred vision. What do we do? Yes, we all know about ethambutol. Ethambutol causes this particular problem. You all know about ethambutol ocular toxicities, right? But there is also one more drug, right? Not but also linezolid induced optic neuritis is not uncommon, right? So yes, ethambutol, once patient is on ethambutol based regimen, stop the drug immediately. Do not re-challenge ethambutol again. You have to replace it with some other drug or the active agent if you feel there is a need to add. If you feel both isoniazid and rifampicin are working, it's okay if you do not replace with any other quinolone group of drug. Continue just isoniazid rifampicin for another 4 months of period. But if the patient is on this drug and you feel that there is a seriously ill case, for example, there is CNS TB or pot spine case where you think you need to add a quinolone group, yes, you can replace it with a quinolone drug also, no problem. So both the drug ethambutol and linezolid also do causes optic neuritis. Stop the culprit drug immediately. Never ever re-challenge this drug. Let me be clear. Do not re-challenge with this drug at all. Just replace it with a working drug. Coming to a next problem, that is arthralgia and hepatitis. What do? Patient comes to you within 3 weeks or 4 weeks of period complaining of joint pain. Sir, दवा खाने के बाद सारे जोड़ों में दर्द है, या घुटनों में दर्द है, या जोड़ों में एल्बो में दर्द है, ये जॉइंट में दर्द है, सभी जॉइंट में दर्द है. बाथरूम में बैठ जाता तो उठ नहीं पाता हूं, सपोर्ट के बिना उठ नहीं पाता हूं. Yes, you are right. Both this problem, that is arthralgia as well as hepatitis, is caused because of one drug, that is nothing but pyrazinamide. Yes. So pyrazinamide induced gouty arthritis is very common. check for the uric acid levels for the patient. The moment patient complains of joint pain, just ask some questions to the patient. Leading questions like, क्या ये दर्द दवा चालू करने के बाद शुरू हुआ है, या क्या पहले से ये प्रॉब्लम था, या दवा लेने के कितने दिनों बाद शुरू हुआ है, so that we come to know it is not only the drug which has caused, but there can be some other cause of arthralgia also, maybe like hypocalcemia, vitamin D3 deficiency. You need to rule out those causes also. It is not only a drug which causes problem always, it can also be some other drug which causes problem, right? So what do we do? Nothing but just send uric acid level for the patient and call him again with uric acid along with the calcium levels of the patient. Check for the calcium levels, check for the uric acid levels, and just fix it up. Do not stop pyrazinamide, do not stop any other drug, not required, just continue the same, and just add fibric acid if the uric acid levels are going too high, right? So next side effects, that is unpleasant, very unpleasant, GI intolerance, vomiting, nausea. The moment you take medicine, it comes out, right? So, and also hypothyroidism. Patient was normal previously, but now patient has come with hypothyroidism. The thyroid levels, the TSH level is went up after some drugs, or maybe there is hypoglycemia, right? In diabetic patients, which other drug? Yes. So ichinamide is one of the drug which causes hypothyroidism or maybe even hypoglycemia in that matter. These are also some of the lesions which are caused because of ichinamide, right? There are multiple hyperpigmented pustules like lesions. They are painful sometimes, right? But they're not itchy at all. The moment they're itchy, it is not ichinamide. These are non-itchy hyperpigmented lesions all over the body. These are ichinamide induced. Reassure, recounsel the patient, continue the drugs. Once ichinamide has been stopped, later on at the end, all these lesions will come back to normal. No need to treat these lesions, right? Coming with a small video over here. Okay, so if you see such kind of patient, you know, who is coming to you walking only on the heels, the toes as well as the sole is in air. Patient is walking on the heels. So the moment patient enters the clinic and the OPD, immediately it should strike in your mind, yes, this is nothing but just peripheral neuro. Play this. Just a second. I'll just try to play. Fine. Okay. Actually, this was a video, but I'm sorry, I'm unable to play this presentation. Different patient. See this. She's just walking. The toes are in the air, pointing up the presentation. A second patient. So this is nothing but peripheral neuropathy. The moment you see the sole and the fingers are up, this is nothing but grade 3, grade 4 peripheral neuropathy. Patient is in severe pain, having a very bad pricking sensations, very bad tingling sensation, numbness. You can see this patient, which did not come walking also. This patient was this was been carried by an attendant. They had to carry this patient and bring to the clinic. If you see the video of this patient. Okay, fine. So she's in severe pain. She's unable to keep her sole down also. This is nothing but grade 4 peripheral neuropathy, right? This is also one of the presentation of a patient unable to keep the sole down. So these are all different patients coming with same presentation. This is nothing but linezolid induced peripheral neuropathy. Isoniazid is also a drug which causes peripheral neuropathy, but isoniazid will not grade 3, grade 4 such peripheral neuropathy. For such kind of peripheral neuropathy, none other than linezolid is the only culprit drug. So the moment comes with the walking on his heel with the sole up, toes up, it is nothing but linezolid induced grade 3, grade 4. But yes, these are reversible. Many clinicians tells once patient develop grade 4 neuropathy is not curable. I would say no, it is not that way. If grade 4 neuropathy is also curable, trust me for this, we can take care of it provided we timely diagnose it, we timely hold the culprit drug, and we manage it appropriately. That's very important. So yes, you need to do nerve conduction test, but nerve conduction test is a costly test. So if you want to be safe medico-legally, you can get it done. But medico-legal point of view, it is better you do it. Better you give a reference to a neurologist. But the moment patient comes to you, the first and the foremost thing what we will do is hold the culprit drug for grade 3 and grade 4 peripheral neuropathies, right? Just hold linezolid, do not continue further, replace it with some other replacing drug is very important over here, right? The moment you see grade 3, grade 4, hold linezolid, replace it with some maybe either delaminate if it is in a replacement sequence. If you feel no delaminate is already going on and patient develops neuropathy, stop delaminate. Then the replacement sequence is the amikacin drug injectable. Maybe you need to add it, or maybe you also need to take help of paracetamide, or even pass in that matter if you need to make your continuation phase a bit stronger, right? So classical presentation where patient comes with a pricking sensation, cactus. Have you seen cactus plant? Just step over a cactus plant. The pain which you will feel is the exact pain what patient goes through. Patient बोलेगा मेरे को झुंझुनाहट हो रही है. अगर patient बोलता है कि मेरे को सिर्फ कभी कभी झुंझुनाहट हो रही है, it is grade 1 peripheral neuropathy. पेशेंट अगर बोलता है झुंझुनाहट के साथ साथ थोड़ी सी मुंगिया आ रही है और थोड़ा सुनपना हो रहा है, चलते चलते समझ में नहीं आ रहा है, नीचे जमीन पे कापूस जैसे लग रहा है, इट इज ग्रेड 2. चलने पे दर्द भी है, पेन बहुत ज्यादा है, पूरा पैर नीचे नहीं रख पा रहा हूं, चलते चलते चप्पल स्लिप हो रही है और पेन नीचे तलवों पे और ऊपर जॉइंट तक बहुत सीवियर है, नहीं सहन हो रहा है, इट इज ग्रेड 3. इतना दर्द है कि ये सहन नहीं हो रहा है, मुझे जमीन पे पाँव रखने भी नहीं हो रहा है, इट इज नथिंग बट ग्रेड 4. So this is a easier way of classifying into grade 2, 4. The moment it is grade 3, grade 4, stop linezolid. Do not even think of re-challenging it. Just replace it. It is very important. That's really, really, really important, right? Next. So what do we do with the patient develops peripheral neuropathy? So if the patient is having neuropathy, stop the drug, replace it with some other drug. Now, pentanoid group of drugs, that is pregabalin and gabapentins, are very good drugs. Trust me for this. Pregabalin 75 once in a day, too sufficient. For grade 3, grade 4, I would say my preferred drug is gabapentin over here. Gabapentin with not repetition of 100 milligram, 200 milligram, 300 milligram, 400 milligram. What we do is grade 1, grade 2, 100, 200 is more than sufficient. Just once in a day for total three months. Sometimes 3 months, 4 months also is required, right? For grade 3, grade 4. We can escalate our dose for gabapentins from 100, can reach to 200, 300, depending upon the grading of the. So if there is a grade 3, grade 4 peripheral neuropathy, gabapentin 200 or maybe 300 milligram once in a day, evening 7 o'clock preferred time, because after that if the patient takes, he feels a bit giddiness, and to avoid this giddiness, it usually been asked to take at evening 7 o'clock time. You can also add duloxetine if the pain is severe. Duloxetine is one of the anxiolytic drug, but sometimes used for very much helpful in taking care of the peripheral neuropathy. So 20 milligram twice in a day or even in a day, depending on the grade, fine. But just keep one point in your mind. Do not add duloxetine with linezolid. It is very important. You cannot add linezolid and duloxetine both together to prevent the serotonin syndrome. Otherwise, the patient will be in a worse state. So if you are thinking of adding duloxetine along with gabapentinoids or along with gabapentin, please stop linezolid and then add duloxetine. You can give duloxetine for a period of even a month's time, no problem, right? So yes, once you give gabapentin or pregabalin, counsel your patient. Do not expect the improvement just within 7 days or maybe even 10 days. It will take good 3 minimum weeks for it to show its effect on your body. The symptom will start reducing not before 3 weeks minimum period. So patient should be called back again after only a month's time, not before that. Should be counseled very well that this is a very common side effect. Even if I would have taken this drug, I would have faced the same problem. So the moment patient is having this problem, just it with yourself, give your example over there that do not worry, just take this drug, you will be fine. Have some patience, give reassurance and counsel properly. If the patient is on BPAL now, okay, and if the patient is come to you with peripheral neuropathy grade 1, grade 2, what you do is you can hold your linezolid for 15 days minimum period, provided you have 9 weeks of BPAL-M regimen. If the patient is not completed 9 weeks of period and has developed neuropathy before that, think of just stopping linezolid, changing the patient from BPAL to a longer regimen. First thing. Second thing, if the patient is on all oral longer regimen and has come to you with a neuropathy of grade 1, grade 2, do not worry. You can reduce the dose to 300 milligrams. So have a close follow-up whether the patient is able to tolerate 300 milligram of linezolid or no. If it is able to tolerate milligram linezolid, continue with all oral longer regimen along with 300 milligram of linezolid along with gabapentinoids, that is gabapentin or maybe even pregabalin in that matter, right? But if the patient has come to you on all oral longer regimen with grade 3 or grade 4 peripheral, do not continue or do not even make it half. Just stop linezolid and switch over to a working drug depending upon the replacement sequence. That's very important, right? So suppose if you are the patient is on BPAL-M and if you are thinking of reducing the drug of linezolid, take care of three things. One, patient should complete minimum 9 weeks of period and patient's ADR should be mentioned immediately to the committee. One thing. And the treatment, which was of minimum of 6 months, now extended 39 weeks. That is very important. So there should be an extension of BPAL-M if you are planning to reduce linezolid. But if you're thinking of stopping linezolid, then BPAL-M cannot be continued. You'll have to switch over to the all oral longer regimen. Okay? Moving ahead. So the small case, the patient was on BDQ, levoflox, cycloserine, clofazimine, linezolid. Yes, this is nothing but just our DRTB case on all oral longer regimen. He was on these drugs for a period of since 5.5 months. Now patient has come suddenly in the casualty with this presentation. So patient was in distress. Patient was in severe pain. You can already see the picture over here, right? So these were the lesions seen all over the body, the entire body. You can see the face, the neck, the trunk, the ears, right? The chest, even the tongue in that matter has got involved. The extremities, the neck region, the entire trunk, the entire lower back. If you can see, these are nothing but necrotic type of lesions. They are necrotic lesions. If you see closely, these lesions are nothing but no, they are not thrombocytopenic purpura. They are not like thrombocytopenia. No. This patient was on bedaquiline, linezolid, cycloserine, clofazimine, and pyridoxine. So this patient suddenly comes up in 5.5 months with such presentation. This was none other than toxic epidermal necrolysis. We could see a proper necrosis of the skin over the lower lesions. They had turned black over there. And this was nothing but because of some drugs. Now, what do we do? The moment you see such problem, such case in front of you, all second liners immediately because we don't know which drug has caused this particular problem. Now, the side effects like maybe 10, maybe syndrome, maybe SJS, that is Steven Johnson syndrome, can be because of any drug. Any drug can be a culprit drug. There is no single drug that only rifampicin can cause this, or maybe only pyrazinamide can cause this, only bedaquiline can cause this, only linezolid can cause this. No, any and every drug can cause such kind of problem. Okay. So now for this case, what did we do? We just treated her symptomatically. We holded all second line drugs. We started with corticosteroids for the patient, and patient was responding to the corticosteroids and gave her some local applicant. That's it. We hydrated the patient nicely. We kept in the ICU. We kept them under observation, and patient was doing well. Well, this is the presentation exactly in 4 weeks of period. All the lesions were completely gone. Now, coming back to the case. So once the patient is completely normal, once all the lesions are gone, now what do we do? Because underlying problem is still there, right? Patient is on second line drugs since 5.5 months. We need to re-challenge drug one by one is what we did. The same thing. We first re-challenge with bedaquiline because that is the drug which we want at the earliest in our regimen. So we started with bedaquiline in the gradually increasing dose in the 3 days period. Once patient tolerated well, no side effects, we added a second drug over there. Patient was given second drug in the same similar fashion, gradually increasing dose for a period of 3 days. Patient tolerated that drug also. Third, after 6 days, third drug was been added in gradually increasing dose. Patients did not show any side effect with that drug also. Surprisingly, she went on tolerating all drugs, all the drugs as the full dose. Now we were in a catch over here. Now what do we do? Because this is what the presentation showed, right? So now what do we do? Yes, we just dig a history further now. So we started noting down all the drugs that the patient was taking. And when we started taking a deep history over there, that time we came to know that patient was been given fibric acid, that is febuxostat, just because patient had developed joint pain. She had visited a general practitioner nearby. General practitioner was being informed that I am on TB drugs. Which drugs, what category of drugs the patient did not inform the GP. So what did general practitioner do? General practitioner just added a fibric acid to the patient, and within 3 days, patient started developing itching, and 4 days she came with this complaint. When we went to the literature of fibric acid, fibrostide drug, immediately what we saw was there is also a rare side effect of 10, which is not uncommon with fibric acid also. So this was not because of any second line drugs, but it was a side effect which was developed because of the other drug which was been given for tackling the ADR without knowing the underlying problem. So our second line drugs or our AKT are not the culprit drug always. You need to take care of the entire spectrum of history, the drug list, what all drugs the patients are on to reach the diagnosis and to tackle the problem. Cardiotoxicity, a next side effect. Very common drug causing cardiotoxicity. The moment this term comes in our eye, in front of our eyes, the drug which comes in mind are always, we all know, yes, bidaculin. बीडीक्यू इंड्यूस टॉक्सिसिटी सब लोगों ने बहुत सुना है. स्टार्टिंग में तो बीडीक्यू अपनाने के लिए भी तैयार नहीं थे. बहुत जब बीडीक्यू जब आया था फील्ड में, बहुत लोग बीडीक्यू इंक्लूडेड ड्रग्स रेजिम में नहीं दे पा रहे थे. क्यों? उनको डर था कि कहीं पेशेंट को कार्डियक अरेस्ट ना हो जाए, कहीं पेशेंट को प्रॉब्लम ना हो जाए, क्यूटीसी प्रोलॉन्ग ना हो जाए. यस, so but that happened, that was not true. So in my entire years of practice, trust me, stopping any drug, rather stopping bedaquiline because of cardiotoxicity or QTC prolongation, it has been hardly not more than 3 or 4 patients. So rest all patients were absolutely tolerating BDQ, but yes, that do not mean that we should be very much lenient and liberal over here. You have to be careful. What do we do? So you need to see QTC intervals. That's very important. For that, we see or check a baseline ECG. On baseline ECG, we check for the Fredericia formula. This is Fredericia formula, right? So Fredericia formula, there are 3 types of formula: Bezet's formula, Fredericia formula, and Framingham formula. So if you see the QTC which are interpreted on automatic interpretation of ECG, it is always because of Bezet's formula. I'm sorry, thank you. So it is always with the Bezet's formula and not with Fredericia formula, right? So if you see the Bezet's formula, the reading of Bezet's formula is always on the higher side. Do not interpret or do not take that as a value of QTC. For QTCs, we need to calculate our QTCs always with Fredericia formula. That's very, very and very important. Unless and until QTC interval is not calculated by Fredericia formula, do not consider that as the ideal figure, okay, or the reading. So which are the drugs causing QTC prolongation? Bedaquiline, quinone, delaminate, pyritonamide, and clofazimine, right? Even high dose FQ is nothing but high dose moxi. So if the patient is on high dose moxi and BDQ and DLM, so combination of these 3 drugs definitely to QTC prolongation, I would agree. But solely with bedaquiline, very less likely, until and unless there are underlying other problems. So what are those? Many times what happens is, what is normal male and normal female now? For a normal male, 450 millisecond is the normal QTC by Fredericia formula, is the normal reading, and for females it is 470 milliseconds for females. So any reading which is lower than this are absolutely normal. Only if the readings are higher than this for male and for female, that too calculated by Fredericia formula is only to be considered, not otherwise, right? Now, so this was one patient where QT interval, RR interval, and the QT. This table shows a clear-cut differentiation between Bezet's formula and formula. So these are the figures which are calculated by Bezet's formula. These are the name of these. If you see 506, which is higher for a male as per our normal cutoff level, right? if this is the 506 milliseconds is a QTC interval, QTC reading, right? Do not start Budacal is not the case. Sorry, what we have to do? We have to check whether the calculation is been done by Fredericia formula or by Bezet's formula. By Bezet is showing 506, but same reading with formula is as 456, which is normal for a male, right? Same way for a female over here, 495 by Bezet's formula, showing 450 by a Fredericia formula. So the message to be taken from this slide is Bezet's and Fredericia. Bezet's always on the higher side. Fredericia is on the lower side compared to the Bezet's formula with the same QT and RR interval. Do not take automatic interpretations. Please calculate manually, or there are apps in your Play Store or on your iPhone. Just go on the Play Store, just download QTC calculator and enter RR interval and this thing, right? The QT intervals, and you will just press enter and you will get the reading automatically, right? So if you see over here, QTC, which is showing 513, is not to be considered. Let me be very clear again over here, because this 513 is nothing but Bezet's formula, because this is an automated correction reading which has been shown by the ECG machine. We have to calculate this particular reading by a Fredericia formula, and then only if it is on the higher side, you may think of bringing it back to the normal. And then, so this is how the calculator, the app looks like. You just need to enter the QT interval and heart rate and press calculate. The answer, the QTC as 467, right? So what do we do? Once the drugs like bedaquiline, quinolone, clofazimine, teleminate, pitomanate, these are the drugs which causes QTC prolongations. The moment the patient is on these particular drugs, you need to think of certain things. Like if you do not correct QTC intervals for our patients, we may also need to talk these points. This is nothing but cardiac arrest, sudden death, and we don't want that. So any clinician who is able to pick up these QTC intervals is really a good clinician, right? What are other causes of QTC prolongation? So it is not only the drug which causes QTC prolongation. Sometimes what happens is also because of the low electrolyte imbalances, like low potassium or low calcium or low magnesium, may also lead to prolongation. Sometimes you may see QTC prolonging drugs like chloroquine, which is commonly used for malaria. A common drug like ondansetron, a drug like antifungal, fluconazole. All these drugs, when they are combined along with our second line drugs, may also QTC prolongation. So we need to be very careful if we give certain drugs to our patients like chloroquine or maybe ondansetron or maybe antifungal drugs. They may lead to QTC prolongations, right? The moment you see QTC prolongations on your ECG, now how do you go ahead? Repeat ECG, recheck the QTC intervals with Fredericia formula. If it is still high, send electrolyte immediately, serum electrolyte levels like potassium, sodium potassium chloride. Send calcium levels for your patient. Recheck the electrolytes. If there is problem with the electrolytes, rectify electrolytes appropriately by measures to be taken, right? Second, check for the drugs which are been added to the along with second line drugs. Are there any other drugs which are been added? If yes, please stop those drugs than stopping our second line drugs, right? Third, if you feel that no, electrolytes are normal, there are no other drugs which have been added for comorbidities, and there are nothing but QTC which is prolonged, what do? You will have to hold the QTC prolonging drugs immediately. How? See. So let us categorize in grade 1, that is mild, grade 2, that is moderate, grade 3, that is severe, and grade 4, that is life-threatening. So in grade 1, when male is 450 to 480, it is grade 1 mild QTC prolongation. In female, 470 480, it is mild grade 1. If the patient is asymptomatic, do not worry. Just check for electrolytes, correct it if they are abnormal, and check for the ECG oftenly in 24 hours. Very frequently, a close follow-up is required. Grade 2, moderate. If 480 and 500 milliseconds, if it is more than somewhere in a range of 480 to 500, and the patient is asymptomatic, what do? Check electrolytes, hold QTC prolonging drugs, rectify the electrolytes before restarting them, and then monitor ECG closely. Grade 3, for a severe QTC prolongation, if the QTCs are more than 500, okay, on 2 separate ECGs, Do not give QTC prolonging drug at all. Hospitalize these patients. You may need to have a very close follow-up. Repeat ECG in 24 hours. Reintroduce the drugs once the QTC come lower than 500 milliseconds. That's very important. Do not alter or do not reintroduce our drugs before that, right? And grade 4, if it is more than 500, sometimes it is life-threatening, and the patient is also having unstable dysarrhythmias. So these are the life-threatening. They need ICU admissions. Hospitalize this patient, rectify the electrolytes immediately, and have a close follow-up on ECGs after every 24 hours. And once the ECG is QTC F is back less than 500 milliseconds, then only think of reintroducing the drug one by one. That's very important, right? Okay. So suppose the QTCs, this is what exactly what we did right now. So the moment it is in the range of grade 2, grade 3, grade 4, immediately hold, electrolytes rectify karo. And what are the drugs causing QTC prolongations? We already have seen that clofazimine, quinolone, delaminate, pritomanate, bedaquiline, any of these drugs, if the patient is on these drugs, hold these drugs, rectify your underlying electrolytes. And once the QTCs are normal, then you can introduce one drug at a time, gradually increasing dose, right? In a period of 3 days with ECGs in every 24 hours. That's very important, right? Going ahead, 3 to 4 days is a period of reintroduction. First drug is always bedaquiline if it is there in regimen. Second group of drug is quinolone, that is maybe leoflox or moxiflox if it is there in regimen. Third is clofazimine, and fourth is delaminate or pritomanate if they are in the regimen. This is how you reintroduce the drug one by one. So you can just take a snapshot of this particular slide. That's important. Next, so this is a small case over here. So this case, the patient was having a baseline of 400 milliseconds of QTCF. Second week 376, 1 month 440, second month 419, third month 429, fourth month 390, and suddenly at fifth month he developed 542. Okay, no chest discomfort at all. What did we do? We repeated the ECG. On repeated ECG also it showed 520. We rechecked whether it is from QTCF or no. Yes, it was from QTCF. There was sinus bradycardia for this patient. So this patient was categorized as severe sinus bradycardia, severe grade 3 of QTC prolongation categorized. And what did we do? Yes, hold it, bedaquiline, pitamarate, linezolid. And then once the QTC is F for lesser than 500, then we introduce one drug at a time. Okay, after reintroduction, if the patient was fine, and this is what the reintroduction took place, right?
Excuse me, sir.
Yeah.
Darshan Bajaj sir is raising hands. I think he has a
Yep.
question.
Please tell me.
Hello, Vikas bhai. How are you?
Absolutely fine. Please tell me. Yeah.
Vikas bhai, I'm a little bit confused between the degree of arrhythmias. So, can you just clarify what do actually mean by the difference between these severe and the life-threatening arrhythmias?
Okay. So arrhythmias are arrhythmias over here. Okay. The moment you feel that these arrhythmias are not common, they are because along with the QTC prolongations over here, just involve a cardiologist over here in your management. Do not do or go ahead singly for medical legal point of view. Add a cardiologist over here and then tackle the underlying problem. Okay. So any
Of course.
arrhythmia in that matter, any arrhythmia in that matter are always right if you and the patient is having underlying QTC prolongations.
No, like there are fibrillations also. So,
Yeah.
what actually we mean by life-threatening arrhythmias and what we mean by severe arrhythmias? Any inputs regarding that?
But cardiologist will answer this question better than me.
Okay, yeah, yeah. That is
Yeah,
why
so any
I was also
arrhythmia, basically,
confused.
if the patient is having arrhythmias over here, you take it as if that is life-threatening, definitely. So grade 3, grade 4 QTC prolongations hai more than 500 or more than 520. Okay, just take care of the arrhythmias over here, underlying problem causing arrhythmias. Hold the QTC prolonging drugs and then go ahead once the QTCs are normal, right?
Thank you. Thank you, Kaveh. Okay.
So as
Thank
we
you so
all know,
much.
something what we mean is like when there is ventricular tachycardias or ventricular arrhythmias, so they are life-threatening arrhythmias. When we call them as VTAC ho raha patient ko, ventricular tachycardias agar hai patient ko, so yes, they are definitely life-threatening, right? So if there is only sinus tachycardia, sometimes sinus tachycardia can be because of just maybe temperature. The temperature is higher than 102, 101, also may lead to sinus tachycardia. So in that matter, it's okay. But if there are ventricular tachycardias over there underlying, yes, involve cardiologist, tackle the underlying problem, and then just go ahead by gradually increasing dose once the QTCF is normal, lesser than 500, is what a message to be taken, right? Okay. So next line drugs also. So first line drugs we all know pyrazinamide, isoniazid, rifampicin are the most common drugs causing hepatitis. And second line drugs like ethionamide, pyramidine salicylic acid, bedaquiline, pitomanid, or even PAS may lead to hepatitis, right? Hepatitis means liver enzyme derangement, SGOTPT higher side. But does it mean that the moment enzyme goes up, we need to stop the second line drugs or the first line drugs? No. So there are certain parameters and the cutoff levels after which we are supposed to either alter, close monitor, or maybe replace, or maybe stop the drugs, right? So how do we do and what do we do? So the first thing is the moment the patient comes with us with excessive vomiting, always ask for liver LFT, liver function test. That is very important because the patient may have a drug-induced hepatitis over there. Second, always also ask whether the patient has developed vomiting only after taking the drugs or was there before also. So only gastritis can also lead to vomiting. Liver and derangement can also lead to vomiting. Electrolyte imbalances can lead to vomiting. Abdominal obstruction intestinal obstruction can also lead to vomiting. So there are many other causes of vomiting. You need to rule out all of them and then conclude and follow this thing. The most important thing is alcoholism over here. Many time patient tells us, ये पानी से दवा नहीं जा रहा है, दारू से बहुत easily दवा जाता है. Very common thing, right? So maybe patient is alcoholic and he is consuming these pills with alcohol, and yes, these are nothing but definitely they are bound to have a drug-induced hepatitis over here, right? BPAL M can be administered to patient with mild to moderate hepatic impairment, but should be avoided in a patient with severe hepatic derangements or impairment. So what are the problem and how do we tackle them? So that we'll see now. Okay, the moment patient is having or a patient is on BPAL M shorter or all longer regimen, having these particular drugs like bedaquiline, pritomanid, maybe PAS, maybe ethionamide, or maybe rifampicin, pyrazinamide in first line drugs. So any of these drugs, if the patient is on, what do we do? Immediately send for SGOTPT, that is LFT, liver function test. Now, in case of the first line drugs, if the patient is having SGOT and PT, which are lesser than 5 times of the upper normal limit, and there is no normal bilirubin, no problem in the bilirubin level, and the patient is asymptomatic, what do? Just continue all the drugs, do not worry, but closely monitor this patient. Maybe the level may go up more further within a week's period. So just call the patient again after a week and ask for the liver function test. If the patient's liver function test within 2 weeks is absolutely normal, do not worry anything, just continue with your drugs over here, right? Suppose in the follow-up, the patient comes with an increased level of, say, SGOTPT, which has gone up more than 5 times than the upper normal limit, even with the normal bilirubin level, or if the elevation is more than 3 times of upper normal limit with 2 times of increase in the bilirubin level, or if the patient is symptomatic even with the normal bilirubin levels, then you will have to consider this patient as drug-induced hepatitis. We will have to hold the culprit drug over there and we will have to manage them appropriately. We told BPAL M regimen if it is BPAL. We told high-dose isoniazid, pyrazinamide, ethionamide if the patient is on short oral longer regimen, short oral DRTB regimen. withhold bedaquiline, pyrazinamide, etonomide, and pass if the patient is on all oral regimen, right? So these are the drugs to be stopped if the patient is on respective regimen. Because if the patient is on BPAL-M, bedaquiline, pyrazinamide are the culprit drug. If the patient is on shorter regimen, pyrazinamide, high-dose INH, etonomide are the culprit drug. If the patient is on all oral regimen, pyrazinamide, bedaquiline, etonomide are the culprit drugs over here, right? So what do we do now? Drugs hold kar diya. Just repeat SGO-TPT or rather liver function test after 7 days of period. Check for the liver function test within 7 days. If there is an improvement, fantastic. What do we do? Now we gradually gradually start reintroducing the drug one by one in a gradually increasing dose is what we do. In the same way as we did for QTC prolonging drugs. जो दवाई हमने होल्ड करी थी सेम इसमें फ्रीक्वेंसी में सेम अरेंज और रीचैलेंज करना है सेम ऑर्डर में रीचैलेंज करना है उसको राइट इफ यू सी दैट देयर इज अ रेज इन एंजाइम्स विद पर्टिकुलर ड्रग इमीडिएटली वो ड्रग को उधर होल्ड करना है और उसको लास्ट में लेके आना रीचैलेंज में ओके सो नाउ ऑर्डर ऑफ रिप्लेसमेंट इज सेम reintroduction should be done by bedaquiline first because we want bedaquiline to be first in our regimen high dose INH second pyrazinamide third and etonomide fourth drug one by one. If the patient do not tolerate these drugs, then it can raise to all longer regimen of our patient. If the patient regimen reduce bedaquiline first, pyrazinamide second in a period of 4 days. 4 दिन में gradual increasing dose LFT करना है, second dose ऐड करना है, normal है आगे बढ़ना है, थर्ड डे पे थर्ड ड्रग ऐड करना है, LFT करना है, normal है फोर्थ ड्रग देना है. तो ये ड्रग bedaquiline, pyrazinamide, etonomide pass in longer regimen and then introduction of linezolid, moxi, bedaquiline, pyrazinamide in case of BPAL-M regimen. These are the drugs and this is the reintroduction sequence to be followed as per the guidelines also. Okay? Next. So next side effect, that is ototoxicity and nephrotoxicity. Both are same culprit drug. We all know that. We are well aware of it. None other than second line injectables, right? Amikacin, kanamycin, capromycin are the drugs which causes ototoxicity and even nephrotoxicity. And that is the reason why second line injectables are been absolute or are been removed from the DRTB management regimens. And we have shifted to the all longer regimens now because we have better drugs than compared to these second line injectables, right? So yes, aminoglycosides are the drugs which causes this problem. They also cause ototoxicity, hearing loss, very common. But if the patient is not having a good first line, a good effective drug for making a regimen, and the patient is feeling short, then you have to bring amikacin also in the regimen. That's important sometime. For example, if the patient is pre-XDR, quinolone already resistant, means the patient will be on bedaquiline, delaminate, linezolid, clofazimine and cycloserine. What if the patient develops severe peripheral neuropathy? He is unable to tolerate just in 2 months of period. Linezolid को निकालना पड़ रहा है, तो क्या करेंगे अभी? तो bedaquiline, delaminate, cycloserine, clofazimine के साथ हमको शायद injectable लाना पड़ेगा. If the patient is on initial intensive phase, that's very important, right? So sometimes we have to take help of these injectables. या कभी-कभी कैसे होता है? Delaminate ज्यादा available नहीं है फील्ड में अभी इस वक्त. तो और पेशेंट अगर bedaquiline, linezolid, quinolone resistant है, तो क्या करेंगे? Amikacin is a drug which has to be come up and brought up as a replacement sequence, right? See to it you engage or keep or ENT in a loop for the management, because nowadays patients are very smart. Patient may try to put all the blame only on you and your drugs. So to be safe, always, whichever side effect we have seen till now, it is very important to keep their specialty specialist in a loop for the management. It's okay if you don't take their follow-ups oftenly or regularly, but at least 1 or 2 follow-ups or references should be there for to be safe medico-legally. That's very important. Okay. Most importantly, once the patient develops ototoxicity, if it is grade 3, grade 4, sensory neural deafness, trust me, it is not reversible. You cannot reverse it again. You cannot. Many times the ENT, they do tell that these are the aids which help. But I would say my practical experiences, these aids also do not help at all if the patient has oral toxicity. Now coming to a nephropathy, that is ENT, if there is a renal derangements, can host please mute the other this thing? Yeah. So what if the patient is having renal impairment, right? Renal impairment, we know the kanamycin, ethambutol, pyrazinamide, quinolone group of drug, ethionamide, cycloserine. These are some of the drugs which have got a clear renal clearances, right? So if the patient is having renal derangements and the serum creatinine derangement, it is not necessary to stop all the drugs. No, this is the chart which you need to follow. It is next to impossible to mug up this chart. You can just take a printout and keep it beneath your table. That's very important, which will help you a lot, right? We have to calculate the GFR of our patient, glomerular filtration rate of the patient. If the GFR is more than 50, in these cases, you can give kanamycin at this particular milligram per kg body weight for per 24 hours. Ethambutol 20 milligram per kg per 24 hours. 30 milligram per kg per 24 hours, and Oflox, ethionamide and cycloserine can be given at 100% dose. There is no need to change the dosages of Oflox, ethionamide, cycloserine and pass. Second, if the GFR is between 10 to 50, then these are the readings. You have to alter the drugs accordingly. If the GFR is less than 10, these are the per milligram dose of the patients where you have to rectify it in your patients, right? Okay, going ahead. Okay. Now, 75 years old, sputum positive, MTB detected high, resistance not detected. What will we start? So, if the patient is just having TB, sputum positive, gene expression showing rifampicin sensitive, what do we do? Yes, come to casualty after 10 days with FDC. We will start FDC. We started FDC for this patient. Within just 10 days, patient came with this presentation. If you see a complete red bleeding lips over here, you can see the eye which is complete red. This patient was been hospitalized. There were also some potential hemorrhages over here. Yes, platelet counts were on the lower side for the patient. We started patient on methylprednisolone, steroid, 40 milligram, TDS. That's what we do usually, right? In ICU. But immediately within 24 hours, patient deteriorated. You can see an active bleeding on the lips, tongues. You can see the necrotic skin, peeling skin. You can see the scrotum, the peeling skin. Entire scrotum was being spilled up. You can see the hemorrhagic, active hemorrhagic lesions over here, right? Face, potential hemorrhages over here. So this was a clear-cut deterioration with methylprednisolone. Now what do we do? So the message over here is steroid always doesn't help for our patients. No, sometimes steroid can deteriorate our patient. So if such presentation, the patient comes with SJS, Stevens-Johnson syndrome, not necessarily always steroid will help us. What we do? Hold all the drug immediately. Do not re-challenge any of the drug. Start steroid. If the patient deteriorating within 24 hours of steroid, you think of something else. Yes, this was confirmed as Stevens-Johnson syndrome, and what we did was we started on cyclosporin. We went with some of the research over here, and then we found yes, cyclosporin was been given to some of the patient, and that's what we did for our patient. We recently found this drug to be a promising drug, and we gave cyclosporin to our patient at 3 to 5 milligram per kg per day orally. It is very thick, viscous-like fluid or viscous-like liquid, which we gave in 2 divided dosages for our patient for 7 to 10 days. Sometimes we need also to give up to 2 weeks of period. Now, what did we do? Yes, the moment we did this, in 4-week period, you can see the change. This is the patient, the same patient, which was having an active oral bleeding lesions. You can see the eye also become normal. You can see the skin over here. You can see the lesions, all clear, absolutely clear. This is nothing but what did we do? We just holded the culprit drugs and we started cyclosporin for this patient at 3 to 5 milligram per kg per day in 24 hours divided dosages. Rechallenging one rechallenging was been done for our patient. Usually for Stevens-Johnson syndrome, I would advise do not rechallenge unless you have a complete backup and a close follow-up and a reassurance and recounseling done to your patient. So that's what we did, and then we started with rechallenging one by one. The moment we start with rifampicin, again what we saw was some bleeding and redness of the eye. And yes, we were lucky enough to catch hold of the first drug itself and rifampicin, and we started. The patient was already tolerating amikacin, linezolid, and leoflox, and then what we did, we decided to start this patient on second line drugs because all the first line drugs were showing problem, were showing bleeding problem, and then we had to actually start this patient on second line drugs depending upon the successful rechallenging. It took a good pretty 1 month for us to rechallenge one and every one drug, and then this was the final regimen which he tolerated, and then finally this patient was been declared cured after a period of around a year. So by this, I just thank you. This is what I could share in 1 hour time period over here. But still, I would be happy if there are any questions. I would definitely like to answer them. Maybe if not now, even later on, if you feel there are some doubts, you all can definitely approach us. Many of the DTOs, many of the AMOs are already contacting us for the for difficult cases. They are doing that. But I would say if you feel that your cases are challenging cases, which you want us to discuss on the eco platform, we are happy to do that, right? So already we are receiving many doubts, many cases. So if you feel some challenging cases to be shared on the eco platform, let us know. We'll do that also.
Hello. Hello. Hello, Dr. Oswal.
Yeah, please go ahead. Dr. Subramaniam, please go ahead.
Shall I ask you one question?
Yes, please, sir.
Just let me know, few of the drugs, even the primary also, they lead to fulminant hepatitis in some of the patients.
Yes.
Can you please let me know at what stage of the transaminase elevations we can say that these are the patients who may go into fulminant hepatitis, and these patients can come back to normal stage?
Yeah. So a very good and very important question has been asked over here. So if you talk about fulminant hepatitis, trust me, there are cases like in my entire 15 years of practice, one case, two such cases we have seen, all fulminant hepatitis, which had drug-induced hepatitis, where we withholded the drug, all the hepatitis drug. The way we discussed just now, we brought down the serum SGOTPT level, bilirubin level, and then we started rechallenging the patient. Rifampicin was been rechallenged first. Patient tolerated rifampicin very well. There was no increment in SGOTPT level on rechallenging of the drug. But when we reintroduced isoniazid, you won't believe, only with 100 milligram of isoniazid also, patient went into sudden hepatic failure, and from normal liver enzyme, he just passed away in just 2 days of period. So sometimes fulminant hepatitis is life-threatening. So if you ask me the cutoff level of SGOT-PT, I would say there are no cutoff sign, because we have seen 3000 SGOT-PT coming to normal and tolerating all first line drugs very well, with the gradually introduction of drugs when we introduce them slowly one by one with a close monitoring. But if the patient is leading into fulminant hepatitis, we cannot expect any patient, even with normal enzyme also, with reduction, sometime he may lead to fulminant hepatitis in just 2 days of period when the enzymes were normal. Okay, so point over here is, so if HOTPT levels and bilirubin levels are too high and the patient is non-alcoholic, hold the drugs, hold all hepatocyte drugs. Within 7 to 10 days, if the enzymes are coming back to normal, trust me, these are the cases which are not to go for hepatitis, fulminant hepatitis. Sometimes, many of the times, 99%, they won't go into fulminant hepatitis, right? Wait for the enzyme to come back to normal. Within 7 days to 10 days maximum, they have to come back to normal. Once they come back to normal, then is the time where you rule out your HIV, HBsAg, HCV, alcohol, and other drug-induced causing hepatitis. Okay, rule them out. Now introduce one single drug at a time, but with a very close follow-up. Gradually increasing dose is the key over here. You have to inform and counsel your patient very well. 150 milligram for 2 days, then 300 milligram for next 2 days, 450 milligram for next 2 days. If you have any problem in any of the drugs, come to us immediately. Get a LFT done immediately. Check for the enzymes, whether it are going up or whether it are coming down. If they are coming down and fine, no problem, continue. But even a normal enzyme can lead to fulminant hepatitis in 2 days also. So there are no cutoff signs, sir, for fulminant hepatitis. It is just that we have to keep a very close follow-up and counsel our patient. It is very important. Now, there are also cases who had drug-resistant hepatitis in our patient in the cases treated for 3 months, 4 months, 5 months, not responsive, got TDM done. TDM showed low rifampicin levels. We had increased even rifampicin to 1200 milligram in a case of drug-resistant hepatitis in a baseline. Now just imagine a scenario, baseline having drug-resistant hepatitis with rifampicin, but later on rechallenged, tolerated all first-line drugs very well, later on non-responsive, got a TDM done. TDM, there was low drug levels. We increased the rifampicin levels. We were very scared because patient had already shown an episode of drug-induced hepatitis. But when you go up with a proper approach and a close follow-up, you don't land up into problem many times. 99.9%. But 0.1%, it's not in our hands, sir. Any other question?
So we have one more question from Dr. Harshil Patel. How to
Yeah.
determine which drug is causing ADR if we see myriad of symptoms, especially in alcoholic, smoker, or HIV positive patients with TB?
Drug? Which drug is causing ADR?
Yes, so how
Okay.
to determine which drug is causing ADR if there are myriad of symptoms?
Okay, so that's what. So for that, that's what we told right now, right? So any drug-induced hepatitis case or either any ADR case, first you have to be rest assured that this patient is off alcohol, off any drugs which are causing the drug-induced hepatitis problem. HCV, HbSAg, HCV are all normal, and if they are having ART, they are along with ART. So there is one very simple formula. If the patient was on ART, he was tolerating the ART very well, and he developed hepatitis after starting off first line drugs. That means yes, first line drugs may lead to this kind of problem. Now you have to explain a patient, get a scan done, get a ultrasound done, rule out cirrhosis of liver, rule out underlying alcoholic liver problem, rule out active alcohol consumption, rule out your other problems, other drug causing hepatitis over here. And then if you find that yes, this is nothing but drugs which are causing, hold the AKT over here, the first line, that is hepatotoxic drug. If it is because of our drug, within 7 days, maximum 10 days, the symptoms should come back to normal. It should come back to normal. So any of the ADR which are because of our drugs, it come back to normal. Drug induced problem, the ADR. The casualty drug is been stopped, the ADR come back to normal. That is very. What minimum panel is useful? HGTPT? No. Only HGTPT should not be done. It should be entire liver function test. So liver function test in entire India, I don't think it is more than 700 even in private sector. So 700 rupees for per week, it has to be managed if the patient is in private sector. In a public sector, it has been done everywhere in public sector for LFT. LFT is not a challenge, if what I feel. This is a question which has been asked. So if you think you can do only OTPT, I would say no. You have to send entire liver function test. It is very important because sometimes we also have to take care of GGT, HGOTPT, total bilirubin. We have to take care of whether is it because of the cholecystitis which is sitting inside or our drugs which is causing problem. I think we have answered questions in the chat box. And still, if any of you all have any problem, you definitely can reach us. My cell phone number, everyone knows my cell phone number. You can WhatsApp me, no problem at all. You are already sharing many of the cases. Many of you are definitely sharing many of the cases. And if you feel they are re-challenging cases to be discussed on this Echo platform, let us know. We can do that. We can take care of them. The challenging cases, right? DRT, challenging cases. Okay, I think we can just sign off. Thank you, Echo, once again for this platform. Okay, there is one question. Any indication to stop entire drug panel other than SGS and Oh, so other than SGS and PIN. Now, Yes. So the question is, any indication to stop the entire drug panel other than SGS and 10? So any life-threatening situation like even Dress syndrome, SJS, 10. So these are some of the life-threatening situations where you have to first take care of the patient and the crisis. You can also, there was one case just last week of diabetic ketoacidosis. A young female, 20 years old female, recently diagnosed as DRTB, and she came in a casualty with a gasping sort of situation. We were unable to, like, when we got a X-ray test done, X-ray was showing a small patch right upper zone. That's it. But patient was breathing very, very abnormally, right? And then when we got a HGT done, it was 500. It was more than 500. So that struck immediately. We did a ketone done. Urine ketone were 4 plus. Patient finally got intubated, and it was DKA, diabetic ketoacidosis, which we're tackling. In such situation, also sometimes we have to not think of our second line drugs, but first tackle the crisis over there. Take care of the diabetic ketoacidosis, hydrate them well, and get the sugar level done. The sugar level come back to normal by insulin infusions and all. The management goes critical level, and then you can think of your second line drugs and RTP management over there. In such cases, whichever is life-threatening situation, you first take care of life-threatening situation first, and then take care of the second line drugs. But in case of second line drugs, the patient is unable to take orally, I would say, meropenem group of drugs along with amoxiclav, linezolid if the patient is not having pancytopenia, levoflox injectable or amikacin injectable if the patient is creatinine is normal. These three drugs are very good drugs which can take care of your rapidly multiplying bacteria, because these three are having bactericidal activity. Meanwhile, you can buy time for taking care of the other drugs and manage the situation over there. Right? Okay. So I think we'll end our presentation over here. Thank you very much once again, Echo Platform. Yeah.
Thank you, Dr. Vikas, and thank you to the entire team of Shatabdi Hospital as well. And thank you to all the participants for joining. I have shared the feedback form link in the chat box. I request everyone to share the feedback form link. Thank you, everyone.
Please do that. Please do that. Please kindly share the feedback. That's very important, because we will actually get an idea whether should we get this kind of sessions regularly and regular intervals or no. Thank you.